Thanks for being here. Today, we're going to talk about Crohn's and UC flares. So, inflammatory bowel disease flares that we see in the emergency department. How should we be thinking through these problems? So let's start by just talking through, when someone has an IBD flare, what are they going to look like when they present in the ED? And we can go through Crohn's and ulcerative colitis.
Sure. Thanks again for having me. So when it comes to patient presenting and saying that they're having a flare of their symptoms, as you said, it depends on what kind of disease they have, as well as disease involvement. Let me start by discussing UC because I think that's a little more straightforward. So ulcerative colitis only affects the colon. So usually a flare in that colitis would appear with symptoms such as diarrhea, so increased in frequency or watery consistency of bowel movements. Patients may complain of blood in stool. And in severe flares, they may have belly pain, fevers as well. In Crohn's, if a patient has colonic Crohn's, then again, the symptoms of flare may be similar to that of UC. But patients who have small bowel Crohn's, a flare in small intestinal inflammation may present with features like, again, abdominal pain, nausea, vomiting. Patients with Crohn's may present with complications such as, a partial or complete small bowel obstruction. So those patients may have severe belly pain, inability to keep down any orals. Maybe they've not had a bowel movement or not passing gas for a couple of days. Sometimes, for a partial or a complete obstruction may lead to a perforation. So then the patients with Crohn's may present with severe abdominal pain, acute abdomen, with fevers, features like that. Or, a small bowel obstruction can sometimes lead to a contained perforation. So they may have an abscess within the intra-abdominal cavity. So then those features would be more, belly pain, fevers, and things like that. So I think you may see a myriad of symptoms, but going a little more into what kind of disease they have, what has the history been thus far, will help categorize, is this truly a flare? And what kind of complications might we be dealing with, and how severe is this?
Sounds like Crohn's can be a lot more serious with a lot more complications.
Right. I think there'll be much more on the differential if you're dealing with a Crohn's patient.
Okay. Well, so then I guess that brings us to the next question of when someone comes in who knows they have IBD, whether it be Crohn's or ulcerative colitis, and they're having what they believe is a flare, or they're having some abdominal complaints or diarrhea, how should we be working up these patients?
Yeah. So I think, okay, again, thinking about the ulcerative colitis patient, because they're going to come with diarrhea, belly pain, blood and stool. So common things to rule out are infection. So I would make sure to send stool studies for GI PCR, ova parasites, C. diff would be the big one. Another useful test to send off for us is calprotectin. So that's the inflammatory marker, which is specific to inflammation in the GI tract. So while you're sending stool studies, if that can be sent as well, that's very helpful for the GI team. In addition to the stool studies,
just asking about the calprotectin. So this is a serum level, or this is a stool?
It's a stool test. It's a test in the stool.
Okay.
It is, like in the blood, the serum inflammatory marker commonly used is C-reactive protein. And that's useful as well, but that's non-specific. And if there's inflammation anywhere else in the body or infection anywhere else, that level can be elevated. But with calprotectin, which is the stool inflammatory marker, when that is elevated, it's much more specific to colitis, like inflammation within the colon. So we usually do track those levels.
So what is that going to tell you? Because is that going to distinguish between, say, a C. diff infection and an autoimmune flare? How are those levels going to be different?
That's a good point. It doesn't help us distinguish between infectious colitis versus inflammatory colitis. But where it might help me is to give me a sense of the severity of flare. Now, if someone is coming with more than 10 bowel movements and blood and stool, then I know, okay, this is a real flare. I know that calprotectin will be high, maybe really high. I can compare it to previous levels. It gives me a sense. But when someone comes with little borderline, I'm having, maybe 1 to 2 more bowel movements than before, I'm not really seeing blood, then, if it's a milder flare and if the calpro is also not that much higher, then we can manage it outpatient.
Okay, great. So I get it. So it's a marker of severity, essentially.
Yeah.
Okay.
So stool studies, in addition, I think the basic workup like complete blood count, as well as complete metabolic panel, because they're often to have anemia, especially features of iron deficiency. They can have dyselectrolytemia. So those blood tests I would get, and in addition, the serum inflammatory marker C-reactive protein can be helpful for us too. Now, in Crohn's patients, depending on symptoms. So CBC, CMP, I think is common, and CRP is common to them as well. If they have diarrhea, I would send all the stool studies as well, previously discussed. And then that's usually most of the blood work that is relevant in the emergency room.
Okay. Then I guess the big question is, when to scan, when not to scan. And I'll preface it by saying most of these patients that arrive in the emergency department are showing features that would lead us to want to scan them. They're having abdominal complaints. They're probably having some tenderness on their exam, and, their white count may be elevated, all the things that lead us to think we should scan this person. So is it reasonable to not scan these people? Sometimes I feel like, wow, this is a 28-year-old guy who's come in 15 times. Do I really have to CAT scan him again and again and again? Maybe I do. Maybe I don't. I don't know. That's the question.
It can be challenging. I can understand. I think so. Again, I think about it this way: in patients with ulcerative colitis, the need for doing a CT scan is much lower. It is recommended by the guidelines to do an abdominal X-ray, because in someone with a colitis flare, what you're looking for is colonic dilation. Like, do they have any features of toxic megacolon? Because then that would change our management. But otherwise, if you do a CT scan, it'll just show thickening in parts of the colon, which will be read as colitis, infectious versus inflammatory. Doesn't necessarily change our management. So I think in a patient with ulcerative colitis, I'm comfortable holding off on the CT scan.
And just getting a KUB to look for toxic megacolon.
Yeah.
Great.
In a patient with Crohn's, I think it has to be individualized. If they've had, a CT scan within the last 3 to 4 months, if they're like what you're describing, they've come repeatedly with similar symptoms within the last year, then perhaps we can hold off on the imaging in that case. But otherwise, if they're acutely symptomatic, features of acute abdomen, fevers, elevated white count, if there's any concern, then doing a CT scan is very valuable, because they can have any of these complications, partial small bowel, complete small bowel obstruction, fistulization and perforation, intra-abdominal abscess. So the only way to ascertain that is with imaging. What type of imaging? So a CT with enteric contrast, enteric contrast is going to be needed to, delineate obstruction. Having IV contrast is very useful to delineate abscesses. So ideally, you're getting it with the oral and IV contrast. Sometimes, if the patient is not very toxic, and if you have a chance to discuss with the GI team, we would then recommend, maybe a CT enterography or MR enterography. Enterography uses special negative contrast to enhance the small intestine a little better. Because again, in patients with small bowel involvement of Crohn's, we want to really focus and take a look at that part better. So we might advise to get the enterography rather than just a plain CT scan. And one other point I'll make it is, again, like you said, these are young patients who are repeatedly needing imaging. So we tend to try to use MR rather than CT to try to avoid the exposure to ionizing radiation as much as possible.
Okay. But it sounds like it's kind of hard to get away from imaging the Crohn's patients unless you have a very good reason not to.
Right. Agreed.
Okay. All right. So that's great. So just to summarize, then it sounds like, lab workup would be CBC, CMP, CRP. Then the stool studies would be PCR, oviparasites, fecal calprotectin, and C. diff. And then for UC, we would add a KUB. And for Crohn's, most likely in the ED, we'd be getting a CT with IV and PO contrast.
Agreed. Correct. Yep.
Okay, cool. Then I guess the question is, how do we manage these patients? let's assume that we're not seeing these complications from our CAT scan or KUB, right? It's not toxic megacolon. There's no fistula. There's no abscess. There's no, perforation.
Right.
But, our labs may come back, but our stool studies probably aren't coming back in a timely manner. So what do we do then?
Yeah. So I think, okay, so again, talking about the UC patient first, if, the way we can triage these UC patients, there's something we use, it's called the modified True Love and BITS criteria, and that helps us categorize the severity of the flare, mild, moderate, severe. Because now I'm making decisions on, does this patient need admission, or can I can I discharge them to be managed as an outpatient? So for a severe flare, essentially the criteria would be more than 6 bowel movements with blood in the stool, as well as either one of these features like fever, anemia with hemoglobin less than 10.5, or raised inflammatory markers. So when I'm seeing a severe flare, I'm automatically saying this patient is going to get admitted. And so honestly, at the level of the ER, you don't really need to pull the trigger on steroids because C. diff and some of the other infectious workup is still pending. So it's okay to just call for the bed and, just hydrate the patient in the interim.
So not necessarily start, empiric antibiotics either. You would just...
Right. So there is no role for empiric antibiotics for UC flare. Even if you're, and again, the GI PCR or C. diff is going to result within 12 hours, usually in our system, 12 to 24 hours. And these patients are usually able to provide a stool sample pretty rapidly. So there's no need to pull the trigger on antibiotics. If in the absence of infection, there is no role for antibiotics in management of a UC flare. So really, the mainstay of treatment is steroids. And usually what we would do is, for a true severe UC flare, it would be IV methylprednisolone, 20 milligram every 8 hours. So sometimes, patient, in the ER, the first dose of the Solumedrol would be given, and that's okay too. If they're waiting on the C. diff results, and if they hold off on the steroids, that's okay as well.
Okay.
So really, there's nothing more for the UC patient there. And also going back to the True Love and BITS criteria, for mild flare, that would be less than 4 bowel movements, no blood, and no fever, no elevated white count, no elevated inflammatory markers, then that's a milder flare, and those patients can be discharged. Usually we give them like a short steroid taper. So that would be oral prednisone, maybe like 40 milligram, and taper it by 10 milligram every 4 to 5 days. And that's usually in conjunction with GI. By that time, I'm sure you would be discussing with the GI team, and they can guide on any particular case. Now, for Crohn,
that's quite a long course of steroids then. I mean, if you're saying 40 for 5 days, 30 for 5 days, 20 for 5 days, 10 for 5 days, that's 20 days or...
Yeah. And again, I think, that's where the GI team comes in, because based on that patient's history, we can help titrate that. Like there are some patients who've, their disease is usually very quiescent, and this is just like this first flare they're having in years, then there I might do a shorter steroid taper. I might start the prednisone at just 30 instead of 40 and taper it by every 3 days instead of every 5 days. Whereas if it's somebody who's been hospitalized before, who has a history of recurrent flares, has recently been switching medications, more colitis-specific medications, and I'm waiting for those to kick in, then I need that steroids to tide them over, to bridge them. I might give them a longer taper in that case. So that's a case, I would say.
It puts us in a weird position to discharge someone without, maybe pending these results, without any steroids, or is it like we should have them come to our follow up with us, or we send them a script and say, don't start these until you get your results? I mean, I guess it puts us in a weird position, because a lot of times we may not be able to get them to see GI in the next couple of days.
That's true. No, but I think ideally a patient with IBD is following long-term with a GI doc. and is in communication with them about this current flare. And so oftentimes, the mild flares, when patients reach out to us, we manage it on the phone. We order these tests, they get it done at the lab close by, and then we prescribe them medicines. We try to prevent them from having to go into the emergency room. So you will not be ideally seeing a lot of mild to moderate flares. It's when there's more concerning features, then we say, hey, go to the emergency room to expedite the things.
Okay, great. All right. So that makes a lot of sense for UC. So we discussed ulcerative colitis, flares, and it seems like there's a pretty straightforward way to navigate through this. For Crohn's, let's assume we work them up with the same labs, the same stool studies, and a CAT scan. And the CAT scan, if the CAT scan was to show something like an abscess, fistula, perforation, I mean, there's no question we're going to admit, we're going to call surgery, we're going to call GI, and we're going to give antibiotics, and that's that. Yeah. But let's say that it's showing that, yes, there is a flare of some sort. Calprotectin is high, CRP is high, and there's inflammation on the CAT scan. What do we do now?
Right. So it depends on where the inflammation is. If it is colitis, so it's inflammation in the colon, I would manage them similar to the ulcerative colitis patient. I'll probably apply the True Loves and Wits criteria. If they're having more than 6 to 8 bowel movements a day with blood and features of fever, elevated white count, anemia, elevated inflammatory marker, I'll probably admit them because this is a more severe inflammation and will probably need some IV steroids. Whereas if it's more mild features, then that patient with Crohn's colitis can go home with a short course of prednisone. Now, if the inflammation is in the small intestine, which is ileitis, again, it would depend on the extent, the length of disease, and what kind of Crohn's-related history this patient has had. If this is a patient who's had multiple surgeries already, has been in and out of the hospital, I would touch base with GI because they may also warrant admission for more aggressive management and more careful monitoring while we treat with inpatient steroids. But short segment ileal inflammation and patient is otherwise, responding to analgesics, tolerating orals, then they're okay to go home even without any prednisone with GI follow-up in the coming few days to weeks.
Okay, that sounds good. So it sounds like for Crohn's, it's a little bit more complicated to figure out exactly what to do. This would be a good place to touch base with GI and make sure they have follow-up. But it sounds like it can range from anything from admission to go home with nothing. Right. Versus the UC patients, at the very least, they would probably be going home with steroids.
Right. Yeah.
Interesting. Okay. And I guess one last question I have for you is let's talk through some common side effects and things we should be thinking about with the common IBD medications that we're going to be seeing.
Sure. I think to begin with steroids, so you'll be well aware, patients can come with hyperglycemia, high blood pressure, especially if they've been on very prolonged courses of steroids. So that's something you may encounter in the ER. The other things that may happen, we put patients on medicine called mesalamine. Patients on mesalamine can have idiopathic pancreatitis. So someone presenting with that, if you see that on the medication list, that's something to think about. Another of our IBD medicines that is associated with pancreatitis is azathioprine. So these two things. If you see abnormal LFTs, so transaminitis, azathioprine can be a culprit, methotrexate can be a culprit. One dangerous side effect with azathioprine specifically is bone marrow suppression. So someone coming in with severe neutropenia or pancytopenia, and if they're on azathioprine, then that's the thing to be most concerned about. And then, our patients of IBD who are on biologics, so those are the immune suppressant class of medications, which we have many now. We have more than 10 types of biologic agents. Anyone on that is immune suppressed and so susceptible to infections, not just common infections, but opportunistic infections, fungal, viral, tuberculosis. So, and that is not GI tract specific. So they may, present with, any sort of systemic features. Right. And if they have IBD and a history of IBD as well as exposure to these medicines, then we need to broaden our differential when you're seeing that patient.
That's great. Awesome. And I don't have any other questions. That was so great.
I think one other thing I'm going to say, which is useful for ER physicians to know as well, apart from giving steroids, the other way we can help manage patients whom you're going to be discharging from the ER with mild colitis is some topical treatment. We do steroid enemas, there's steroid foam, mesalamine suppositories. That all of that helps to give a lot of local relief. So while the patient is waiting to see GI, some of these topical therapies will help get some of the healing going, in addition to the prednisone that's being prescribed.
Tell me a little bit more specifics about that, because I don't think I've ever prescribed that.
So the mesalamine topical, the brand names would be Canesa suppository or Rovasa enema. Suppository basically works within the rectum, and enema will reach a little beyond up to the sigmoid colon. So if at all, you've gotten that CAT scan and it's showing more extensive inflammation along the left side of the colon, then, along with the prednisone, you can prescribe an enema, basically to be used once every night for about 15 to 20 days. And that will help with the healing process. Similarly, there's hydrocortisone enema, or it's also called hydrocortisone foam. The foam stays within the rectum and the enema will go to the sigmoid colon technically. And so those can also be prescribed. Sometimes insurance is a little picky and doesn't cover all of the products, but it'll cover one for any one particular patient. So when the EMR will prompt you about which is perhaps the medication that's covered for the patient, and that can be prescribed.
And that would be for ulcerative colitis or Crohn's.
Correct. Crohn's colitis, basically with colitis.
And both of those patients can take that if they're taking steroids or even if they're not taking steroids.
That's right. I mean, these are topical medicines. They have no systemic absorption, and they're just providing a little extra relief, an anti-inflammatory effect within the area that's most effective.
That's great. Awesome. Well, thank you so much.
Well, I'm glad. And GI is always happy to help.
If you say so. I'm just kidding. No, thank you. That was so helpful.